Good morning to you all. I'm Dr. Rajesh Kiran Kumar, Assistant Professor of the Department of General Surgery. Today we are going to have a class on metabolism in response to injury, one of the basic chapters of surgery where it gives you a complete idea of what happens to a patient with an injury or any surgery done on him. Okay. So topic for today is metabolism in response to injury, and by the end of the class, you're supposed to know the basic physiology of metabolism and nutrition, and malnutrition, and the response to injury, and the principles of nutrition therapy. Though principles of nutrition therapy is another topic, we will just go into the principles, but not into detail. But before that, we'll have to go through the basics of metabolism, malnutrition, and metabolic response to injury. And first, when it comes to basic physiology of metabolism and nutrition, you all know from your first years, from the biochemistry class, you even remember that burning carbohydrates, like for 1 gram, you have 3.4 kilocalories of energy produced, and for proteins, you have 4 kilocalories of energy produced for 1 gram of proteins, and for 1 gram of fats, you have 9 kilocalories of energy produced. And the energy production, it depends on if it's an aerobic metabolism or anaerobic metabolism. In aerobic metabolism, you have more energy produced, whereas in anaerobic metabolism, the amount of ATP produced would be obviously little lesser. So we would go in, so before going into this thing, the basic physiology would include the metabolism of carbohydrates from the time of their absorption to how they actually are stored or utilized for energy source. Same thing for proteins and fats, and then continue further. Now coming into carbohydrate metabolism, glucose actually is one of the major source of carbohydrate metabolism. Though fructose and galactose are also the others, but they are minor. And after complete digestion of carbohydrates, you would have glucose as one of them. What happens to this glucose after actually it is absorbed? Now, the glucose is absorbed from the intestine goes to the liver, where actually in the liver it is actually produced into or converted into glycogen for future use. So this process, as you all know, it actually is called as glycogenesis, genesis of glycogen from glucose. And now only in energy required states, like in case of a trauma or when somebody is using lots of energy, then this glycogen is broken down to glucose for production of energy. But for now, when actually somebody is self-sufficient, when a patient is self-sufficient with energy, the glucose is produced towards glycogen. Now, why is this glucose important and how is it important? Now, this glycolytic pathway uses glucose to produce ATP for cellular metabolism. Now, I would like to show you another slide where actually in a picture, you have a glycolysis going into the cytosol of a cell and then later into the mitochondria for energy production in the Krebs cycle. Okay. And you also should know the terms like glycogenolysis and gluconeogenesis, kind of revision from your first year's subjects. Glycogenolysis, it's a breakdown of glycogen into glucose for production of glucose and further energy production. Gluconeogenesis is another pathway where the glucose is produced in a new form, from either a protein or a fatty acids. Okay. So you should be aware of, you should remember, you should get to your memory about glycogenolysis as well as gluconeogenesis prior to going into the metabolism completely and how energy is produced. And now, when we come to lipid metabolism, same thing. Dietary fats actually are absorbed in the form of triglycerides. After digestion, are stored in the liver and adipose tissue. Now, for the absorption of fatty acids, you need or fats or lipids from the bowel. You need lipase enzymes and emulsification of these fats. The same enzymes, the lipase, gastric lipase, as well as pancreatic lipase, all these things, they emulsify the fat so that they can be absorbed from the bowel, and then they are mobilized towards the liver. And once they reach the liver, with the help of glycoproteins, they are transported to the adipose tissue for storage when somebody is self-sufficient with their energy production. But whenever the body requires energy, or whenever the patient actually is undergoing a surgery or under trauma or is exercising, when energy is required, the body would mobilize the fatty acids back from the adipose tissue into the cells actually into the liver for production of energy, that is gluconeogenesis. So how lipids help in energy production? So when required, adipose tissue releases fatty acids and glycerol for energy production. Again, this requires lipases, break down the triglycerides, and then back into the production of glycerol and fatty acids into the liver. Again, gluconeogenesis from that. Okay. And now this oxidation of fatty acids, called as beta oxidation of fatty acids, occurs in the mitochondria in the liver, produces ATPs, and then ketone bodies which can be used as energy source by cardiac, renal, and skeletal muscles. And glycerol can have the fate of gluconeogenesis, ketone produce. So lipids also are a source of energy, though they are not an immediate source of energy for energy production. They do form producing glycerol minor, which actually helps in the gluconeogenesis, and ketone bodies, which are very much used by the cardiac, skeletal, and the renal muscles. Now the protein metabolism, all know again protein metabolism. After digestion of proteins, we get amino acids, and these amino acids are absorbed from the bowel, and they move to the liver, where actually they are transported for as the building blocks. So proteins, all these are called as building blocks. They help in the building up of muscles, and whenever we require energy, they are broken down back again from the muscles towards the liver for production of energy. And you again here to the question of how proteins are used for energy production, the alanine and glutamine amino acids, which are produced by after the breakdown in the muscles, they are transported to liver for gluconeogenesis. And one term you are supposed to know in here is nitrogen balance. Nitrogen balance will tell you about the self-sufficient state in relation to the protein metabolism. It is given by the formula here. You can see on the screen. Total nitrogen balance is equal to total nitrogen intake minus the total nitrogen lost, which is in urine, plus a factor which is added as 2. Okay. Imagine if a patient is a person is taking a lot of protein, the intake is more. Okay. And by the end of protein metabolism, you have urea, which actually is NH2 and H2. Okay. And the N in that nitrogen unit is measured, which is actually in the lost in the urine, and that is subtracted from the intake he is having, and factor B2 being added. So you get the nitrogen balance. When we say then there is positive nitrogen balance, it means that the intake is more. It means that it is towards anabolic state where more muscle is produced. Whenever we say a negative nitrogen balance, it means that the loss is more or intake is less. So you would have more of proteins being mobilized for energy production. Therefore, the body reserves will get lesser. So that means it is catabolism, and the patient is becoming cachexic and he is losing weight. Okay. Now this is a clear small thing of summary of whatever I've been talking to you. You can see here glucose, okay, which actually is producing glucose going into glycolysis cycle, which after a cycle produces pyruvate, and this pyruvate enters into the Krebs cycle after going into the mitochondria, produces energy. Okay, this is the fate of glucose, and whenever self-sufficient, the glucose actually is mobilized towards production of glycogen. Whenever we require energy, glycogen is broken down back by glycogenolysis, and then this glucose enters into the glycolysis cycle, and then later into the Krebs cycle, and to produce energy here, mitochondria and ATP here. The same thing with the fats here. The fats again, which are stored in the form of adipose tissue in the peripheries, they are again broken down with the help of an enzyme called high sensitive lipase. I'll again later we'll come to that by how high sensitive lipase comes in. Okay, and those fats are mobilized for energy production. Beta oxidation produces acetyl CoA again into Krebs cycle, again ATP production. So this is how energy is produced whenever you are in need of energy, especially in case of a trauma or a thing. Here again the fate of proteins is also the same. Whenever proteins are broken down into amino acids, again part of it goes into the production of urea, which is lost in urine. The part actually the amino acids, the alanine and glutamine previously we were talking about, they enter into the Krebs cycle. Again, they help in the production of energy. So the ultimate thing, what happens in case of a catabolic state is the glucose is mobilized towards the cells and the mitochondria, where it is broken down and then produces energy. The same thing the fats, and the same thing with the proteins too. Here you can see the fate of fats, especially one of the catabolic hormone will catecholamines, okay, acts on these receptors producing HSL here, high sensitivity lipase, and this lipase goes down and breaks down all these lipids, the triglycerides producing glycerol and fatty acids. And now this glycerol, actually we were talking previously that glycerol enters into the gluconeogenesis cycle and then produces glucose again, and then glucose enters into the Krebs cycle, glycolysis cycle, and then later Krebs cycle. The fatty acids which are released after breakdown of triacylglycerol again, they enter into the mitochondria of the cells, they undergo beta oxidation and produces energy, ATP, as well as ketone bodies. Okay, I hope you are clear till now. So with the background of this basic physiology of metabolism, till now whatever has happened, we know that the glucose is the immediate source of energy whenever we need. So in stress or a salient feature of metabolism, we can say that glycogen is a primary source of energy, and the body glycogen stores are used up in 48 hours. How much ever you take, the stores which are used for initial energy production is all based on glycogen. So for the first 48 hours, a person uses glycogen. And then after once glycogen stores are over, now the next source or the immediate source of energy after glycogen would be proteins. So therefore, these proteins are broken down after glycogen is done and towards energy production. That is why a patient, if you knew, would become thinner and thinner after a major surgery, because proteins after third day are broken down to produce energy. Lipids now, when you come, are not useful as primary because the fatty acids can be used for gluconeogenesis, only glycerol used. Okay, fatty acids are used for production of ketone bodies, which can be used only in certain tissues, and the amount of energy produced would be lesser. But only the glycerol is the one which actually goes and forms immediate source of energy, glucose, where that is why body does not depend on lipids for an immediate source of energy. Instead, it depends on a glycogen and the proteins here. The fatty acid oxidation produces more energy than one glucose molecule. If you go back to your classes in on biochemistry, where fatty acid oxidation produces a lot of ATPs, whereas one glucose molecule produces lesser ATPs. And all of this fatty acid oxidation or any cycle in the Krebs cycle occurs in the mitochondria if and if only oxygen is there. So it is called as aerobic metabolism. In case of an anaerobic metabolism, lactate is produced from the muscles. In the muscles, you get lactate. All of you can have sore muscles when you exercise a lot. That is because of the production of lactate and accumulation of lactate in the muscles. And this lactate again is produced transferred out to for production of energy. But though pyruvate is formed from lactate, if you consider glucose turning into a lactate, pyruvate, or a lactate turning into a pyruvate, the energy used or utilized for production of pyruvate from lactate would be more compared to glucose. That is why it would use up energy unnecessarily rather than producing energy in case of anaerobic metabolism. So the patient would deteriorate if his oxygenation to tissues is lesser. Okay. And now, till now, we have discussed about the health features. First topic for today, the basic physiology of metabolism and nutrition. And now we would go to malnutrition. And in relation to surgery or in relation to any malnutrition, there are three distinct syndromes. Okay. The first one would be starvation associated. Second one would be chronic disease associated. The third one would be an acute disease or injury associated. Um, as a surgeon, I would like to tell you all three of them are associated or related to surgery and a trauma related or a major surgery or a minor surgery related. First, if we go to starvation associated, what would be a starvation? Now, starvation actually is a mismatch between the supply as well as the demand to the patient. And if he has to receive like 100 kilocalories of energy, but if actually his energy which he receives is lesser than 100 kilocalories, now there would mobilization of all these resources, whatever he has stored all this while for energy production. So he will become thinner. So that is what is starvation. So there is a mismatch between the supply and the demand. And in relation to surgery, all the primary illnesses in surgical patients can result in starvation-induced malnutrition. Okay. One of the examples being the patient not being able to tolerate orals. Whatever we take food, he would vomit out. It could be any reason. It could be a growth or something obstructing the esophagus or obstructing the stomach, whichever is not, when the food is not passing down into the bowels for assimilation, absorption and assimilation, rather than actually it is not intolerated and then it is thrown out as vomitus. Or it could be a dysphagia where he is having a difficulty in swallowing, so his oral intake overall would come and would decrease. So the nutrition supply would come down again. Or if you imagine if he's having postprandial pain, whenever he's having pain, a person would tend to take lesser food. Again, this would actually again result in a decrease in the supply compared to a demand. So again, starvation sets in. Or in case of repeated NPO restrictions, imagine if there was a patient who needs some investigations where NPO is required, or a minor surgery where NPO is required. So the patient is kept NPO for few times in the hospital admission. So he would be in a energy supply. I mean, like demand which being reduced. So therefore, the NPO would actually decrease the nutritional intake or nutrition supply. So again here, when you come to the metabolism, when we link the metabolism and again the starvation thing here, the glycogen forms immediate source of energy. In the first 24 hours, it is used up. By around 20 to 24 hours, it is used up because there are no source or no, because of chronic starvation. The chronic nutritional intake has been less. So the amount of glycogen for usage would be lesser. So the first 24 hours, the glycogen source should be used. And later again, chronic breakdown would be there. But one thing and one good thing when it is related to starvation is that the malnutrition causes starvation response to restoration of nutrition. So if you provide the nutrition or if you provide food for this patient who is starving, the body would respond easily. This is in very much contrast to what we are gonna learn next, especially when it is stress or especially when it is trauma. That is what is our main class about. Okay. Now a little on your protein energy malnutrition syndromes, kwashiorkor and marasmus, which you must have learned in biochemistry. A little you can see here on the left or on the right of the screen, you can see a kwashiorkor baby who looks little chubby and who looks well fed, but you know that actually it is only the lean body mass is very less, the muscle mass is very less, except it is just edema. But whereas in case of marasmus, you can see on the right side of the screen or on the left side of the screen where he's totally malnourished. You can see him, his rib cages are out and all. So both the kwashiorkor and marasmus, it is nutritional deficiency or the intake is lesser. It could be both in developing as well as developed countries. Most of it is always in developing countries where the nutritional intake or the financial status of the family is lesser, where the children cannot meet with the requirements. Or sometimes in developed countries too, when a child is neglected. So there are some clinical features here. For kwashiorkor, you can see in preschool children 1 to 5 years of age, due to low protein intake. Okay, so there is no muscle mass formed. There is no building blocks at all. Mild growth retardation, as in if it happens in a childhood. Okay, mild reduction in body weight. They would have a chubby or protruding abdomen and subcutaneous fat reserve. Ribs are not prominent because there is subcutaneous fat, because that is reserved. Only proteins are lost. Okay. Poor appetite, they can have an enlarged fatty liver because the liver is working more. There would be edema present, that is why the baby looks chubby. Okay. They'll have a moon faces where they have lots big cheeks and they do not have, they don't have any sunken things. So they have moon faces, they have sparse hair, flaky paint-like skin, lethargic, requires adequate amount of protein. You just provide them with protein, they would actually improve a lot. This is what you're talking about, malnutrition. The last sentence here, malnutrition caused by starvation, response to restoration of nutrition. In case of marasmus, it is in weakened infants less than 1 year old due to low calorie intake, total energy, it's just not the proteins. It's totally low. That is why you don't have the fat also, and there is no edema. That is why you just see the rib cage protrude out like that. So, and even the cheeks have gone in. So, due to low calorie intake, severe growth retardation, severe reduction in body weight, shrunken abdomen, and subcutaneous fat not preserved. That is why you can see the rib cages are more prominent. Therefore, you have prominent ribs here. Voracious feeder, he feels a lot of this thing, but in case of kwashiorkor baby, he is lethargic. So there's no fatty liver. Edema is not present at all. No hair changes noted. Dry and wrinkled skin, alert but irritable. Requires adequate amount of protein, fat, and hydration, and that would improve his status. Okay, it's a little on kwashiorkor and marasmus. Later now we would go into the main part in response to an injury or response to a surgery or response to a major surgery or response to minor surgery. Now the screen shows here the surgery is an injury, surgery is a stressful condition, and surgery is a hypermetabolic state. Okay, for before entering into this, we should know what is a hypermetabolic state and all. So what happens in a hypermetabolic state? The body either can be in an anabolic state or a catabolic state. You know, anabolism is building up, catabolism is breaking down. In a hypermetabolic state, when the metabolism or the basal metabolic rate in a patient or in a person is more, it means that it is moving towards catabolism. So profoundly, this alters the substrate metabolism. So it mobilizes all the carbohydrates, fats, and proteins towards energy production rather than storing and building up the body, and helps the organism to adapt to acute injury or illness or surgery, because the body would need energy in case of a injury or illness. Therefore the body will try to produce energy by mobilizing all the stores to the production of glucose in glycolysis, in Krebs cycle, and then production of energy. That is how it is. So anyway, previously we have all seen uh, I was talking to you about metabolism of fats, where catecholamines act on the receptors producing high sensitivity lipase. Now here, the third line here says, immediate response is catecholamine surge, causing release of glucose, lipolysis causing fatty acid metabolic mobilization towards liver, and suppression of digestion and protein synthesis. Okay, and in this hypermetabolic state, which is a stressful condition, in surgical patients or sepsis, there will be mobilization of fat stores, there will be insulin resistance, there will be hepatic gluconeogenesis, there will be suppression of ketogenesis, there won't be any ketogenesis in contrast to starvation. In starvation, you have ketogenesis produced, okay? And there would be a profound protein catabolism. All proteins are broken down. Now, why do we have insulin resistance here? The second point here, we all know why there is ablation of fat stores already, because we need energy production. So the fats are broken down, triglycerols, the fatty acids enter into beta oxidation, and glycerol produced from the triglycerol break down, and then this glycerol enters into the gluconeogenesis cycle. Okay. Now, why do we have insulin resistance here? As we all know by now, there is an anabolic state and catabolic state. We should categorize all the hormones which help in this. So anabolic hormone, insulin is an anabolic hormone here. So whenever insulin is more in the concentration, it would mobilize all substrates for energy conservation rather than catabolism. Whereas on the other side you have glycogen. Okay, I mean you have this thing catecholamines. Then sorry, we have catecholamines, and then we have glucagon on one side, and then you have thyroid hormones. Okay, these hormones are catabolic, and then they break down and produce glucose for energy production. So now, if body requires energy, now we cannot have insulin going and building up this, pushing this glucose into cells for storage. So the cells would show resistance to insulin, so that only the catabolic hormones can act. So this way, patient will develop insulin resistance. And one of the common example of insulin resistance is a diabetic foot patient, where whenever he has an infection, when he is in sepsis, because of insulin resistance, the body glucose levels will be higher. Okay, so that is why he'll have hyperglycemia because of insulin resistance. And again, stress actually breaks down to produce glucose. Therefore, you'll have hyperglycemia. But because the body again takes, because the digestion suppression is there, because of catecholamine surge, again the oral intake will be lesser. There will be lesser glucose intake. So all the reserves which are there in the body are mobilized for this thing. Okay, for energy production. And there is a thing for hepatic glycogenesis, I have already told you, and profound protein catabolism. And after 24 hours to 48 hours after glycogen is used, protein is mobilized for energy production. And now stress response is mediated by the release of pro-inflammatory cytokines. This is what you're supposed to know. These cytokines actually help in the production of energy through mediating the catecholamine surge. The secretion of cortisol, glucagon, and catecholamines occur. Which cytokines stimulate production of these. The sepsis initially caused hyperglycemia due to stress response. Later, causes hypoglycemia due to decreased visceral blood flow. You should also remember, in catecholamines, these are actually flight and fight response. In fight and flight response, you have the blood supply to the heart increased, to the brain increased, and to the muscles which is increased. And the blood supply to the visceral organs or the GI tract is decreased. When the GI tract blood supply is decreased, the digestive system does not work properly, and therefore the absorption of nutrients would be lesser. So it totally by the end causes hypoglycemia, which we're talking about. So you can see here in this graph, where in major trauma, how actually the metabolic rate increases, okay, and then comes down to normal. Whereas in a minor trauma, it increases only during the first few days, and then it becomes normal, and then okay. But in starvation, the metabolic rate is always lower. Okay, and there is no energy production at all. Okay, you should know this. And now this is a little on how a body would respond in terms of stress. You can see here all things whichever is increased, ACTH is increased and growth hormone is increased. Actually, these cause a more mobilization of adipocytes or fats towards energy production lipolysis. Adrenaline and cortisol increase. These stimulate hepatic gluconeogenesis. You have glucagon increased, and all these cytokines here. You can see these are the cytokines IL-1, TN alpha, tumor necrosis factor alpha, IL-6, and IL-8. All the cytokines, they stimulate production of cortisol, glucagon, and catecholamines again. And again, you have breakdown of glycogen, breakdown of proteins and fats, and have insulin here in the end, which actually there is resistance for that. Okay, so this hypermetabolic state will produce cytokines, pyrexia here, cytokines because of cytokines here, you have pyrexia, and all these things happen, producing more and more of glucose and breaking down the muscles and making the person thinner and thinner. So to summarize, we know that for now, anabolic hormones, insulin is an anabolic hormone, and catabolic hormones, cortisol, glucagon, and catecholamines. Okay, and why is there need for this neuroendocrine changes? It is that the anabolism is postponed, and there is more energy production towards the time of need. Okay, and to optimize host defense, because only when if the host has energy, he can fight the infection. Okay, he can have more broken products, albumin and pro-inflammatory proteins, okay, and provides essential substrate for survival at that point of time when the body is in stress. Okay, now we come to that's the end of the response to injury in a surgical patient, and now we come to the last topic, the principles of nutritional therapy. Nutrition therapy is a separate class again for you all people, but we'll just go into my principles, just into the superficial part of it. Okay? And how does nutrition help the stress response? And now we all know that glycogen is used up in the first 24 to 48 hours. Imagine if we are giving that glycogen or glucose in the first 24 to 48 hours of the patient, the stores can be the stores can be kept for some time, so the body will not, and there's no breakdown of proteins, and therefore the patient's state can be maintained. Okay, though the response is not totally reversible during the acute phase, supplementation of nutrition helps in reserving the body stores. Okay, as previously we were talking, in starvation, the person would respond to nutrition. But in case of a stressful condition or an injury or a major trauma or a major surgery, they may not respond completely, but at least that the body stores can be reserved. Okay, the cytokines have already been released because of stress. They're not going to go down till they provide the host some defense. So till that point of time, there will always be breakdown of products for energy production. But if we provide nutrition in this crucial time of the patient's life, we can reserve the body stores for him. Okay, thus prevents muscle wasting, maintains protein-related functions. Now, one of the important proteins in our body is albumin, which actually carries all these inflammatory substances for fighting an infection or a stressful condition. Now, for understanding how to supplement the nutrition, we need to assess the nutrition status of the patient. And methods of nutritional assessment, we have these are the subheadings, and then I'm not going to go deep into it. There will be another class on nutrition assessment, but at least for the basic things, can through a history you can know, asking how his oral intake is, if he has lost weight and all. That through that history you can know if there is any decreased nutritional intake or malnutrition, the body weight, the body mass index, energy expenditure equations. These are all high level, but it's okay. There are some equations where they measure the energy expenditure by the body, or indirect calorimetry, where the heat production in the body is in direct relation to the energy produced. So therefore, that also would give you the nutritional assessment of the body. Dual energy X-ray absorptiometry, where X-rays are used to know the lean body mass. Okay, the different tissues of the body absorb X-rays indifferently. Therefore, when the absorptiometry of the X-rays is done, you can know which of the tissues actually is more fat or like proteins or bony. Okay, and biochemical measurements, which includes total protein levels, total albumin, serum albumin levels, serum protein levels. Okay, and measurements of nitrogen balance. We talked about nitrogen balance, which has total nitrogen is equal to intake minus the lost in urine plus Mn2. Okay, the factor 2. Okay, so if we know the nitrogen balance, then we can say if it is towards a positive or negative nitrogen balance, towards anabolic or a catabolic state. Okay, and now to which patients are we supposed to initiate nutrition? The same thing which I have written here is there in this in this box here. You can see if somebody is ever having a past medical history of severe undernutrition or a chronic disease, then he can actually be given nutrition in a very perioperative period for if he has to undergo any other surgery. Okay, if he has an involuntary weight loss which is more than 10 to 15% of usual body weight within 6 months, or more than 5% within 1 month, if he is having so much of weight loss, it means that there is malnutrition, and then we are supposed to provide him. This forms one of the criteria for providing him nutrition. The other, expected blood loss. If he is planned for a major surgery, and if the blood loss in the surgery is estimated to be about more than 500 ml, which actually forms most of the like 1/5 of the blood supplies. So you are supposed to provide him nutrition. Or if the BMI is lesser, is a underweight person, 18.5 BMI, or it's a term called failure to thrive when a baby is not able to, especially this occurs in pediatric groups, where a baby is not able to thrive even after nutrition. This you can diagnose by comparing it to some growth charts. Okay, that can be done in pediatric age groups. If the serum protein levels are the source of energy, the indication of a nutrition assessment. So if the serum albumin levels are less than 3, you can give him this thing. Or if you anticipate there will be that you cannot give him orally for 7 to 10 days after surgery, then he is supposed to. In a catabolic state, like if the patient, if he's a burns patient, or if it's in sepsis, or if it's in a major trauma, like in road traffic accident and all, or in case of pancreatitis, metabolic diseases and all, he is supposed to have be in a catabolic state. He needs a peri-operative or a nutrition support. Okay, this is a basic. This is how would you give nutrition to the patient? The first thing is always use the oral route if the GI tract is fully functional and there are no contraindications for oral feeding. Only if there are contraindications for oral feeding, then you can use a parenteral route. Otherwise, always use a GI tract or a enteral route for feeding him. Okay. If the enteral route is contraindicated or not tolerated, use the parenteral route within 24 to 48 hours in patients who are not expected to be able to tolerate full enteral nutrition within 7 days. Okay, this is the last slide anyway. And after nutrition assessment, if he belongs to any of the criteria to initiate support, as we saw in the box before, in this box here, if he fulfills any of the criteria here, then he, depending on how the GI tract is functioning, if it is not functioning or contraindicated, then you can go to parenteral route if it is contraindicated. If it's not contraindicated, you can use oral route. And again, oral route also is not possible, is possible, then you can do this. And then here you have enteral nutrition. This one, I'm so sorry, this one you can, there will be a detailed class on nutrition therapy and how to provide nutrition, the different routes of nutrition, nasogastric, nasojejunal, you have gastrostomies, you have jejunostomies, all of this will be discussed in another class for you people. Okay. This is the end of the class for now, and by now you already know what is the basic physiology of metabolism, and then what would happen in case of a stress or a surgery, and then what are we supposed to do in case of a malnourished patient who's supposed to undergo surgery. Okay. Thank you for listening to the class. If you have any doubts, you can just uh, refer to my mail address pradyush.kiran@gmail.com for any further queries. Okay. Thank you so much for listening to the class.